I see a future not too distant where you have a human at top or human at adjacent and bunch of AI agents working for you and directing and orchestrating a lot of things. This human AI kind of interaction will become very important. Technology or any kind of thing is change management. As we now move with AI and technology, we have to rethink our organizations. This is the time where you can say, can this allow me to see 100 patients and provide the care in a differentiated manner? Is that possible? Problem is that people are not recognizing it fast enough. And, even MSOs or GIs, or you talk to them, they are not recognizing. They're saying, no, no, the world is not going to change. No, the world is changing at more faster than you can ever imagine.
Sap Sinha, very warm welcome to the Scope Forward show. You're the Chief Operating Officer of Allied Digestive Health. I've been looking forward to having this conversation for a very long time now. So we're finally here. So welcome once again.
Thank you so much, Praveen, for inviting me on your show, and I'm very honored. And hopefully, what we will discuss will be helpful to your show listeners. So, thank you.
So, Sap, there are a few people in gastroenterology who somehow don't seem to belong inherently to the GI space. And like me, I see you, as one of them. You come from a business background, you come from an economics background. Post that, you seem to have gone through consulting. And yet here you are in healthcare and in gastroenterology. So just to set context, I'm curious to know, how did that happen? Was it out of interest, or did it just happen that you're here at Allied and in gastroenterology?
You are exactly right. After I have an undergrad in economics and I joined consulting then. And so consulting, investment banking, those areas are interesting because they expose you to a lot of different industries. So did that for a bit. Then typically people go get their business school degree. I had the fortune of going to University of Virginia. And during that time, I had actually a professor, Professor Teesberg, who wrote the book Redefining Healthcare with Michael Porter from Harvard. And she exposed me. We had a strategy class, and the whole class was around healthcare. And I was an immigrant who had come to this country, and I had no idea about healthcare. I may have experienced one or twice, and I was appalled how different it was, even from coming from India. And so I understood a lot of the mechanics of healthcare, and that created interest. Where after business school, I got into healthcare consulting. That was a lucky break. I would say that I was in healthcare because recession really didn't affect me at the same way, and allowed me to, continue working, be exposed to healthcare. And that's how I started my healthcare journey in the United States. I had clients, pharma, medtech mostly, and I did a lot of work as I started to mature in my consulting career. You need to find a niche. And then I more and more focused on a lot of medtech pharma companies who are, very large and wanted to invest in healthcare or technology, but we're not capable of doing that. So this was the earlier days of venture studios, which is now a pretty common thing. And then that itch of, being in this environment and creating organizations and being in the owning the P&L led me to say, okay, rather than advising, which is great, I was exposed to very good ideas. I want to be in the business side of things. I got a very lucky opportunity in a private equity back to run a P&L, so that they then got acquired by Optum. So I stayed there for a bit. And then I exited that out to come to Allied Digestive Health. I was looking at few different industries, and I'm personally invested in some. Mental health was a big thing. Women's health was a big area, and then gastroenterology. And the reason were somewhat similar, that there was a recognition that these are important healthcare aspects. And all three have a peculiar thing. there's general shortage in healthcare, there's severe shortage in all three of these. So that was an interesting place where then you could apply technology in a differentiated way, and there is a little more receptiveness of that versus other areas like anesthesia. It's very hard to apply technology in that kind of area. So that was my interest, and I got a, again, very fortunate position at ADH. And so when the private equity invested, I was the first hire in March of 2021, and then my journey with ADH started. So it's been wonderful. When I joined, we were about 200 odd people, 54 GIs, 10 nurse practitioners. Now we are close to 200 GIs, 80 nurse practitioners, about 100 odd anesthesiologists. We have a nutrition business, pathologists, etc. So it has seen a tremendous growth with building a technology infrastructure.
Congratulations on your journey as well as that of ADH. The question I have is, when you came on board, were one of the first hires, what was the agenda given to you?
The agenda was typical, right? Private equity, they have some sort of a playbook at that time. Remember, this is again 2020, 2021. Leverage is cheap, interest rates are nowhere, people are just buying all these kinds of organizations. It was the heydays of PPM world, right? And so there was obviously this pressure to acquire. I think there were pressures in the sense that what they had, generally how a private equity kind of investment thesis works is that there is some sort of a consulting firm would say that these are the things you need to do. And those playbooks are similar, right? Invest in maybe growing an ancillary pathology and build maybe an anesthesia business. Anesthesia actually kind of accelerated just because a lot of the larger groups like Envision and Team Health and Napa in our region kind of collapsed. That gave us the opportunity. So that was more accidental than planned. So those are the typical elements. Change maybe the operational structure a little bit here and there, and build the infrastructure of the MSO because the MSO, even though it was built, it was designed for serving maybe 50 docs, not 200, and that is a different scale you have to work at. So that was the mandate. Remember, we were coming out of COVID, so there was a huge turmoil in the healthcare delivery sector, right? We had lost a lot of people. We retained some of our good people, such as our clinicians and nurse practitioners, nurses, but a lot of the front desk had gone away. So that allowed me to think, okay, that I do not have the opportunity to rehire, because everyone said, oh, we'll just go rehire. Those people had moved on. They needed jobs. They went to the Amazon or somewhere, because these are $20, $25 an hour, got better healthcare, opportunity to grow, etc. And they left. So then who you were hiring were generally not healthcare background. And healthcare front desk is unique. You have to understand how to read insurances card. You have to read co-pays. You have to know how to schedule, as you understand, clinicians schedule also differently, right? Every physician has a little bit of a different, like I see IBS patient for 30 minutes. I see colonoscopy for 15 minutes, but someone else could be different. So there was a lot of elements, and everything was paper-based, ADH. So, patients used to fill 15 pages of form when I came in. So it also gave me the opportunity to just look through the patient journey, redraw it, and say, where are the gaps? And instead of rehiring, training, and doing all that, why not adopt technology and kind of mesh the human element and the technology together to build an infrastructure which is scalable, right? Because the scale which we have become 4 times in 4 years, and we have not, broken as a company, and we continue to perform well. That was how it was thought through. And so every element which you see in our business, may it be HR, may it be the front desk, may it be RCM, you talked about initially pre-autonomous coding technology, which we are using. We have added certain things. And obviously the clinicians, we were one of the first few to adopt GI Genius, test it out. We have now pretty much had GI Genius across the board. We use ambient AI. We were one of the first few to test out Suki when ambient AI, 2, 3 years ago came around. And now pretty much we have everywhere. We even influenced one of our EMR partners to adopt Suki, and they call it now G-Scribe. We have been, ahead of the curve because there was a real shortage. So instead of just doubling down on the same thing, it gave me personally and the organization to rethink. And also, people talk about, oh, physicians don't want to change and all these things. It was an inflection point for them. They knew that there was no people to hire. They had seen it. They had just gone through a pretty bad situation where, you remember telehealth has been around for 10 plus years or 15 years now. It's been around since 2008, 2007, and no clinicians adopted. But within 1 month, every doctor knew how to use a telehealth technology, right? So I truly believe never let a crisis go. Just don't do the same thing after a crisis. That is the best time where people are open-minded because they have gone through change, they're used to change, right? And that's what we did. We used that as an inflection point to change a lot of the way the MSO is structured and dealt and very integrated, which has hopefully helped us to differentiate.
Fantastic, Sap. Now, for people listening, in full disclosure, ADH is a client of Next Services, my business. So it gives me some insight in terms of the operational model. And I know that people will be interested in knowing very structurally how you go about planning your operations from a technology standpoint. Let's say digital first approach, or when digital is possible, applying that approach. So can you systematically break down your operations from a technology standpoint on how you think about every aspect? You mentioned a few areas, but take every aspect and share how you've applied tech, maybe with your own team. You've told me before that you have technology engineers, data scientists working with you. You work with a variety of vendors, and we don't need names and all of that, but I'm interested in how you think about this and how you structure it together.
So first, we redrew the whole patient journey. So from start to when the patient thinks about us to ultimately when the patient is paying for us. So from searching us, your marketing elements to it, to coming in and how they interact, to booking appointments, then coming into the office and how the initial interaction happens, to how the clinician interacts, what information they have, what technology they use. Then once they have left, how the revenue cycle process works. Then going into the post-revenue cycle, payment collection, intelligence around denials, et cetera, et cetera. So that whole journey was drawn. And then where we started was first, thinking about what is the platform, the middle layer, as you say, a middleware, right? What we need, which will allow us to even do certain things. That was a very important step for us. So we actually went away. So we used to be on a GGastro GPM kind of platform. We went to Athena's practice management, as you know. And the reason we did that was Athena was an open architecture. It allowed others to play with it, right? Epic is a very closed architecture. You need a lot of permission. GGastro was similarly designed. Athena had this marketplace, a robust marketplace. Anyone could play in it. It had what, people talk about API, and I don't want to go into their Fire connections. They allow for that, which allows people to connect. It's not just a pipe like an HL7. So those kinds of things was very important. That was the first step. It's like, what is our middleware which will allow us to do that, right? And so once we identified the middleware, and it was not like Athena just came about, we did a whole RFP process and we looked at different technologies and felt, okay, this one is most flexible to allow other partners to play with us. Because, as much any EMR practice management claim they are the best, technology moves on the venture side, right? It's very hard for large organizations to invest. And I told you in my initial journey, very hard to replicate and create in an exponential way because they are trying to serve their own business, right? There's this Clay Christensen, he was also ex-BCG, the innovator's dilemma. There's always an innovator's dilemma in an existing organization. So that was the first thing. And then we shifted our focus, the first step, towards revenue cycle. And the reason we did revenue cycle is nothing goes well without cash, right? So we started concentrating and thinking about how are we going to organize a revenue cycle team so that we are better at collecting cash. So obviously with partners, outside vendors, we obviously outsource certain things. We were a very insourced, everything happening onshore, not very cost effective, and then also very difficult to manage because bigger and bigger RCM teams, you need layers, etc. So I knew enough about technology and I understood the aspects of what it requires. Coding is nothing but an algorithmic insight, right? There's a book, you have to understand it, and you have to code according to the language matching, which is extremely machine learning. There's no AI involved. It's a machine learning aspect. So that was an easy inroad into digitizing something, right? So we did that. And we looked at, this was the early days. Now I think people have matured a lot more. And now AI is kind of involved because there is like word matching and there's fuzzy matching of you may have said this word, but that word may mean three different things. That is happening. But this was very rudimentary word matching with the book, right? And so we invested in that, actually hired better coders to work with this machine learning. So we upgraded our talent. We exited, most of the team, upgraded some of the talent. And then what we could not do, because there are things we could not do through machine learning, we outsourced it to firms like yours and others who could, put the human element, but the human element was a lot more cost efficient than doing it onshore. So that's where we started. And then once that engine worked, people saw money, people saw success. That allowed me personally with my private equity, with my physicians and others to say, okay, let's now adopt technology at other places, right? And because we had that middleware, we could do certain things such as, digital check-in. So we have digital check-in through a couple of different organizations. An appointment accelerator software where when there are cancellations automatically without anyone in the front desk looking at it, can move appointments. We have online, scheduling. Even when we do work with ZocDoc, it's live scheduling with them because Athena and ZocDoc can integrate that way. So we are not selling time on marketplace like ZocDoc's prior business model was. And even when patients were searching us, we used algorithmic things to drive patient satisfaction. So when I joined, if you were to Google Allied Digestive Health, we are the same organization. We have great clinicians, right? That's the secret sauce. You obviously need those great clinicians to do all these things. You would have got very, very bad reviews. You would have said, oh my God, I shouldn't even come to this organization. It was like 1.9 out of 5. Now, the same organization, 4 years later, if you Google us, it's 4.9 out of 5. It's not like the people changed. It's that we became smarter in how we cultivated that population, which was being used to serving healthcare the same way as they do Amazon, right? Any patient now uses ChatGPT to put their symptoms, or Gemini, which is fine. In some ways they come more knowledgeable. Some take it too far. Anything can be taken too far. They will come with 10 different symptoms and tell the doctor this is a medicine. That is taking it too far. But understanding your symptoms, simplifying what the doctor is saying, I think that is a great use of AI from that perspective. So we did that. And then as we moved on, we started in different places. We started putting technology. So now we have come to a stage where we are optimizing it. So for example, we are using technology where the recall, let's use recall as an example. This year is a huge focus for us, is how do we ensure that the volume, especially the recall volume, where we have a medical liability, right, to bring them back in. And then what has been the traditional way? You maybe send a text message. Now you send an email. You may call them, or you send a letter, a postcard. People still do that, right? It's a rubber stamping, like so that I did all my three choices. So if the state comes in, I've done my work, but it's not closing the loop. So if they don't come back, there is no data around unless you are obviously, sitting on and tracking every patient to see, did the patient come back in? Did we actually do something about it? And so we are now using technology where AI agent is completely trolling through, and they can through all our medical records, and that can be done in 10 minutes actually. Even though we serve 500,000 patients, it can be done in 10 minutes, and then identify gaps of care. So it could be that a physician actually wrote in their note, instead of writing a recall, that this patient should come back in 6 months because they didn't get to do a colonoscopy for various reasons. They had some healthcare issues. They said, need to do a colonoscopy 6 months later, please call. But it's not in a recall section. So the team misses it. The AI agent reads through. It can be in your notes. It can be anywhere in the medical record, reads through, identifies, and then contacts the patient saying, you were supposed to come in 6 months, through a text message. That's the simplest. I think, people respond actually better with text than voice, even though the voice agents have become very good. Text message, do you want to book? Please, here's a link, go book a time, right? And so we have been able to do that even for recalls where the recalls have been closed. We have seen, and there's no schedule, patient is not scheduled. We can then go back and doing that. So that's now the next level of using technology to actually enhance, where there is still a human element, because sometimes there's complexity. We don't have time. All our physicians are overbooked beyond, right? There's a shortage in GI. So they will sometimes call, and then the front desk can optimize based on, like, okay, sometimes this doctor actually can see two patients at the same time. So we will double book them because they are bouncing between rooms, those kinds of things. But listen, that kind of information at some point will get fed into the AI agents, where the AI agents will say, this doctor has this preference, or afternoon of Friday, there's cancellation more so you can overbook the patient so that your utilization is 90%, because clinicians are your most expensive. Nurse practitioners and GI physicians are your most expensive resource. So we are moving towards that. So that's kind of how we think about, is that we look at, okay, we have a problem. We knew this was a problem. We couldn't solve it 4 years ago because the technology wasn't there. But now the technology has advanced enough that we could partner with some of the startup companies and really shape the product as we want it to be. And that's what is happening. So it's been great to see how we could, tackle certain problems across. And then ultimately, it has to have a positive ROI. This is not a, just pipe dream kind of experimentation. There's positive, it. If the patient comes back, has a office visit or even a telehealth visit, then comes back for a procedure. Procedure creates professional fees, facility fees, creates anesthesia, creates pathology if cancer is detected, and finally it improves outcomes, because if we do detect cancer, we can quickly get them back out, versus if we would have not gone back and this patient, for God forbid, gets cancer, and it's a late stage, where GI cancer detection earlier it's not a death sentence, right? You can have a very long life now, and it's amazing how medical science has improved. So you can really improve that. So it has to have a good patient satisfaction. It has to have a positive ROI. It's not just an experimentation for the sake of doing experimentation.
So I'm very geeked with your response. I can be all over it. I'm actually reminded of this quote that the future is already here, but not evenly distributed. You see that, so I think gastroenterology has got the expanse of people still doing things the traditional way. And then there's you is taking a hybrid approach with the old and emerging into the new. And it's fascinating for me to see that. I have a fundamental question, and that
Mhm.
relates to money and physicians and getting approvals and all of that. A big choke point for most groups is that the payout model, you generate a certain amount and then that gets distributed to physicians based on whatever model, eat what you kill, or like,
Yeah, and work however you
yeah,
model or
yeah.
equal distribution. Yeah, yes, you're 100% right.
Or like they like to say in the industry, whatever the private equity overlords dictate. Like, so,
Yeah.
whichever model, right? Like, so in that, how did you take out money? Because a lot of this requires investment upfront. I kind of know your response based on what you just said too, because you're proving ROI and you hit the revenue cycle first, which is very, very smart. But I'm interested in some level of detail on how a board meeting would run, or how exactly did you earn that trust or convince a large group of physicians who might have 10 different opinions. This is the classic choke point for many mid-sized and large groups where they can't get alignment and people unwilling to invest, let's say even $1,000 per head
Mhm.
to move the ball in a certain different direction. So, how did you circumvent?
Compensation model is generally a hybrid model. So what that means is, and I think that does matter. So that you've hit a very important point where there is a aspect of productivity, which has there's an element of that because you want to encourage that for sure. But there is also aspect of equal sharing. So this hybrid kind of compensation model allows that any success, there is obviously people gain across the board. That's one fundamental difference. Maybe if you were to step back and look into physician organization, nailing that compensation model, which allows for innovation, is very important, right? Now, going back to, there will never be 100% alignment. There's not 100% alignment between our 200 GIs on how to treat IBD, right? So having an 100% alignment on something is very difficult. Think about even the advent of nurse practitioners. I can tell you how much like my patients don't like nurse practitioners. I am in a very expensive where they're always used to seeing the doctors because that's the financial background. We introduce a nurse practitioner, suddenly she has 3,000 visits a year. The reason being, it doesn't matter what pay scale wealth aspect you are there, when you have GI issue, you need to see a clinician. The GI is not one of those fields that I'm just walking in for fun, right? If you have extreme diarrhea, you have extreme stomach pain, you need to see a clinician. And whoever you can find at that point is going to be accessible, right? So there is this idea, obviously, there's reticent that I'm not going to, and there's never going to be alignment. What we have done is because we are a large enough organization, we have said, okay, who's interested? Is there anyone to bet on this? Right. And so we take those and then do a pilot with them. And once they see the pilot and the ROI, because there has to be a positive ROI and there has to be a positive ROI story. Same with the GI Genius. When we launched GI Genius, there was so much like I'm better than GI Genius. I already have high ADR rates, all those kinds of things. So then we took a couple of groups who said, all right, we will test it out. We backstopped that investment. So the physician wasn't paying. And once they saw the results, then we shared it back. And then it was pretty like, okay, let's use this. It is helpful. And there is an ROI for it because if catch more cancer means that you have higher pathology and then that has an ROI, right? So that was how we have done it. So right now we are testing out AI agents for scheduling. So with multiple different companies because I'm not sure which one is the best. So we have a cohort and we are in 2 states. So we are going to do with one company in New York, one company in New Jersey, couple of different practices who have raised their hand that they have a huge, front desk turmoil in the sense that people are leaving. They just are not able to manage. Patients are complaining that they can never get to them. So said, all right, This is a solution. Do you want to test? So there has to be some sort of a burning platform which the clinician is raising, because these clinicians are, especially in an independent group, are business people, right? In some ways, because they ran their practice. They may have joined a larger practice, but they ran their business in some form. So when you present the solution, okay, you have a real problem. Do you want to test? Intellectually, they understand that. And we test it. If it doesn't, and we have tested multiple things. So I'm just talking about success stories. We have had failures. We have tested, didn't work, and said, all right, shut it down, right? There were things like autonomous scheduling for clinicians. It was actually still easier because we are not that complex. We are not a hospital where we have 20 different things that happen. It was like, okay, this technology is not helpful, right? So we shut it down. Similar with the ambient AI, most of the use case is nurse practitioners and new patients for our clinicians. For follow patients, it's no point opening an ambient AI technology. They just type it, right? So technology is not omnipresent across the board and has to be used. We just have see that once we have enough of a use case. So for example, what I talked about, the recall thing, we tested out in 2 places, have had success. We presented it back to the physicians with the results, showed the ROI. Now they're asking, when should I have this? Now, obviously, the problem is you can't release all these things. You have to be very systematic. So obviously, this physician will call, I am more important because of this. So you should put it. So then we have to create this whole list of how the implementation plan would be. Good place to be in. But those are the kinds of things which we have to do. But the buy-in is not trying to force it on them, because that's never going to work. There will be an organ transplant kind of rejection. So we'd rather have people step up, and there's always the first mover. And maybe that is because we are a large group, that there's the first mover. And there is also, they have some sort of a trust coming, that because maybe my background, a lot of my team, I have a very, very good team. Like my senior VP of operations used to head equity research desk of Morgan Stanley. I have my other senior director of operations. She came from the practices, turned around one of the most successful practices. And so they have organizational trust. It's not just Sap Sinha is saying, it's like the people they work with, they have organizational trust in them because of their backgrounds, what they have achieved, what results they have got. And that allows you to do certain things, of course, because then you have an inherent trust. But if I had come in and said, I'm going to change all these things because I'm saying it wouldn't have worked. I had to have some success story. I took RCM because when you have RCM success and you are seeing more money and lower cost in kind of billing, is an easier sell. Okay, SAP did that. All right, maybe that makes sense. He knows what he's talking about. Okay, now let's go to the other areas. If I had gone and said, do GI Genius day one, they would say, you've not even been in GI. How do you know even if this works, right?
Excellent response, Sap. I think that's so helpful for people listening to think through on how they can tackle their own internal challenges.
And technology or any kind of thing is change management. As we now move with AI and technology, we have to rethink our organizations, right? We have to we redraw our organization charts, where now there's technology there in healthcare where you may not need a 20-member FP&A team. You need a couple of people, and a lot of FP&A analysis can be done, and your P&Ls can be created. Even AP processes, right, can be done automated. We are right now working with a company, a startup, and everything on that area where supply chain, AP, all that processes are getting automated. But that's change management. You have to handle, because people's jobs are getting affected, of course. And there is a personal relationship. Many cases, the physicians may have had this employee for 20 years. So how are you going to create a right position for them? And there are new jobs that are coming up all the time. As I said, coding, we now have more coding auditors than coders, right? Because it's not that autonomous coding goes away. And also when Insurances create medical policy changes, which they do all the time. By the way, we never like we it's like suddenly a different insurance will have a different policy, right? Around something that, oh, I'm allowing FibroScan, I'm not allowing FibroScan, I'm not doing this, I'm doing that. And those kinds of things you have to keep track. And then someone has to teach that in some ways in the autonomous coding. So there is new kinds of job and new kinds of things which are created. Obviously, there is be certain people who cannot adapt and they don't have the curiosity to adapt. That will have an effect on them. But change management is very, very key. Otherwise, the organization will break apart.
Let's expand out a little bit, go beyond gastroenterology, even go beyond healthcare. As someone who is playing the role, that you do, I'm sure you have your own views on where AI is going, where exponential technologies are going, and where the world in general is moving. I'll leave the question pretty broad. I'm curious to know what are you seeing on where everything is going?
AI and large language models, which it's created, they have basically, with the advent of faster and faster GPUs, chips, they are able to process a lot of information, right? And what is that? Their base knowledge is the knowledge of the whole world, right? But they don't know how your process works. So AI agents is like a young child who has to be molded, right? So that is where the world is, where you have to, the same kind of employee program of employee training programs you will have to have an employee training program around AI agents and teaching the AI agents and how they're going to work and interact, etc. So I think that's where all organizations, irrespective, healthcare or otherwise, have to redraw, as I said, their organization structure where the human will be and human aspect will be created, and where there can be AI agents. Where I see a future not too distant where you have a human at top or human at adjacent and bunch of AI agents working for you and directing and orchestrating a lot of things. So I think that's very important, that this human AI kind of interaction will become very important, and people who are open to that is going to be important. The other thing I see because of AI is that, software engineering is dead, right? Like, if you were to look at 2 years ago, 5 years ago, how many software engineering jobs were there? There is none to be hired, right? Most of this, like Microsoft 2 weeks ago announced maybe a large chunk of their software engineers going out because AI can mold that. What does that allow you to do? The cost of launching something which is innovative has gone down extremely to a lower point. Where you and I, if we are smart enough and understand how coding works at a certain level and how AI in some ways works, and we can really understand the edge cases, which is called in the AI world, right? What are the exceptions? We can create something which could be very, very powerful, right? So individuals, you don't need the massiveness of Google's and Facebook. I'm sure they will have an edge, right? But an individual, small organizations can test out and play in different areas which they couldn't have earlier. So I think innovation will accelerate because you don't need that massive infrastructure. You can go to Amazon, buy some space on Azure, get their AI agent models, and start experimenting, right? And that is happening. That's how companies are getting rolled out at this moment. So I think there will be a lot more innovation now, because there will be thousand flowers blooming and allowing for different things. And then there would be, as any industry, right? Few winners will come out of that. But I feel like this is the perfect time to see a lot of individuals playing around and creating certain things which can move us forward than, just doing what we were doing before. So I think that's the understanding, which has political as thinking, right? Because we don't have the even in the US, India, everyone, like what is the AI kind of law structure? I don't think anyone has come, and I don't think our politicians are there to even comprehend what is happening, right, at the root level. And the other piece is because it is so natural, right? Like Chat GPT or any of those, I have never seen a technology being so adopted so well. Like physicians, we joked around telehealth was around for 10 years and it took a COVID national crisis for them to adopt it. I have physicians who use open evidence, Chat GPT, and all those things. And they admit it. They put in some of the diagnosis and they're like, okay, it actually has some element of answer which they can use in their, finally treating the patient,
Yeah, they
which
can
is
refine
amazing.
it. They need not go with it, but they can definitely refine
Yeah, they can
what it
refine it.
is. Yeah.
They're not taking it, but they will, it helps in the thinking process. Like a great writer is not going to, the Chat GPT writing is not going to match it, but it can give you 100 ideas on what you could think about, right? And because it's a language model, I think, it's interesting enough that being able to write and read well is going to become more important in these kinds of scenarios. So, people who read the classics, who, in when growing up doing the Sanskrit and all those things, and Latin and everything, and have really good writing skills and language skills, will actually profoundly, because prompt engineering is nothing but how do you teach and language and all those things? It's nothing to do with math and science. By the way, ChatGPT is horrible in doing math. I've tried doing that. The the numbers don't match ever because it's a probabilistic, and that's not how math works. But that's kind of the world we are living in, where language will matter. Our education system has to rethink where it's not teaching for function, but teaching for thinking in many ways. And our staff and teams is like, listen, if you have a problem, think about it, and maybe there's a solution AI can provide. So having that mindset is going to be very important.
So you mentioned change management earlier, and you also mentioned that you saw or heard, one of my recent talks. If you noted, I refer to something called as the Valley of Death.
Mm-hmm.
There is definitely the holy grail with AI and all these exponential technologies, but we're going to go through this valley of death where there's denial, resistance, frustration, overwhelm, confusion, job disruption, and all of that. I'm curious to know your take on that. First of all, are you seeing it similarly? Do you see societally, industrially, us going in that direction where we go through this valley of death and then come out of it? If yes, what's going to happen, like, at scale, all these jobs? How are you even? I'm not asking specific to your business, but I'm just, extrapolating it in general. How will you even retrain so many people? There's a bigger problem here. You can retrain provided the individual or the group of individuals are willing to get retrained. The bulk of them actually resist change.
You are hitting on a very fundamental thing. Obviously, you and I don't know if we have a proper, correct answer. I think, first of all, education system in many cases has failed us, right? It was a very industrial education system, which has been designed to just keep you moving, right? It doesn't really test your core skill set. Yes, it tests you like, okay, but even if you score 50% or 100%, you keep moving, right? You go to the next grade. If doesn't matter which child, and then the differentiation happens where the 100% kid might have certain opportunities, and then 50% kid will have certain opportunities. So I think there is this element of rethinking our education system would be very fundamental in that. I don't know how you can train if you don't have fundamental skills of learning, right? Curiosity and all those kinds of things. That's absolutely a case. And the problem is many people have not fathomed the speed at which we are moving, right? Because as I said, you keep track of all these GPU like models and everything, and you see, right, every 2 weeks there's a new model coming out. Literally, right? Gemini 2.5 came out 2 weeks ago. I'm sure OpenAI's will come up with that. Anthropic will come out with that, and then there are other businesses, Perplexity, and all those things. So every 2 weeks we are getting smarter by double and more than double than the last model, right? And so the speed at which we are moving and what we can do and the voice we can generate and all those kinds of things, it is absolutely bonkers, right? And so I think the problem is that people are not recognizing it fast enough. And even MSOs or GIs, or you talk to them, they are not recognizing. They're saying, no, no, the world is not going to change. No, the world is changing at more faster than you can ever imagine at this moment. By end of the year, I may have a whole recall system where I may not have people, right? That change is so fast. So I think we have to fundamentally think about, to be honest, even for myself, is like, what is life, right? Is life related to job or related to doing something else? What does money exchange mean? And everything, obviously, I'm very fortunate. I'm at a certain level, at a certain age of a hierarchy, and because I've been ahead of the curve in that sense, I might be fine for some time, but I may be redundant in 10 years. So that's where there is a whole kind of societal shift. And I'm sure we are seeing politically across the board, all those things, that is going to happen. And because the traditional model of going to school, going to college, doing all these things, getting your first internship and all those things, that model is, I don't see it lasting for a long time. There's a fundamental rethink for society we have to do with these technologies being there.
As we wrap up our conversation today, I would like you to take a moment and please speak in an unfiltered manner without holding back at all, which you have. Like, this whole conversation has been super, super insightful. And I'm sure people listening or watching will get a whole bunch of ideas to move in the right direction. I want you to not hold back and just simply give your direct advice to the GI community at large. Where are we and what's coming, and what should people do and not do? Anything that comes to mind to you?
First of all, fundamentally, why we have been successful in doing this is it started with the middleware kind of thing. So, this whole idea that my EMR is sacred, my practice management is sacred, and all these things I will not change. Totally agree. How EMRs been implemented was the worst thing how technology should be implemented. Nobody denies it. Nobody fundamentally should deny it, right? It was a forced thing, didn't work. The experience was UX, UI, everything was bad, right? I totally get that. But there is a time now to step back and say, listen, I need to have a different kind of organization. I need to have that. So I should not be afraid of that change. So first, making sure that the middleware. And to be honest, like I have had initially ambient AI, people were, even though this technology is helpful, where you are not writing, you are doing that. There was so much pushback. Oh, it costs like, $300. My Dragon costs $99. I'm not going to, but you're forgetting that you're not doing bedtime pajama work. You are, getting better notes, which has actually better implications for your coding, as you know, right? You may miss something because our brains don't remember everything. Like this 60-minute conversations we have had, I don't remember everything I've said, right? And if you ask me to transcribe, I won't be able to transcribe. So that element of this reticent to that, oh, technology, I'm not going to adopt. I think it's time to play around and experiment and see what works, what doesn't. Everything will not be perfect. There will be a lot of failures, but we should be okay with failures because failures teach us what is the right thing, right? In life, failures, we have all failed multiple thousand times, and that has helped us to say, okay, this is I'm not good at, this is what I'm good at. So that fundamental idea that I'm not going to change, I'm not going to, my EMR practice management is sacred, because to be honest, the way ambient AI, the EMRs may become irrelevant because you will only be interacting with the ambient layer, and the EMR will be just a recording software at this moment. The way the technology is moving and what I'm seeing right now, even coding and autonomous coding and all those things, the ambient layer could do it because they're already structuring the data and putting in the right sections, right? What does it take to put a CPT code and a diagnosis code? That's the idea that we have to, and not be like, okay, the old way will remain, has to be out of the window. We are going through this process. Like we are short on every kind of person. And then we have to think about that healthcare is failing most of us, right? That we do not have, like we don't have enough GI fellows. And the retirement cliff, like average GI age is what, 55, 57? The retirement cliff is going to be huge. There's no way the medical schools are being created at that pace. So this is the time where you can say, can this allow me to see 100 patients and provide the care in a differentiated manner? Is that possible? Right? Because ultimately we are going to be short on people. So the doctors shouldn't worry, or the nurse practitioner worry that they are going to get replaced. That's not happening. Maybe our lifetime, 20 years, or 30 years, maybe not happening. So, but we have more patients we can see, right? Right now, demand outstrips supply. So think about it. Wow, can ambient AI allow me at the same time to quickly, move around? Can I use AI technology to do differential diagnosis and then see more patients than required so that everyone can get healthcare? This can create new access points. At this moment, access is whoever has the connections, right? Even in GI or oncology, who you get to that doctor. Like I get invariably a phone call from my friend, hey, trying to get with your doctor, 2-month wait list. Can you push? But that's not a sustainable healthcare model. So I think we have to be very, very open-minded and allow where instead of saying this can replace me, how can it expand me? Right? The best of the doctors who use this technology to expand their reach, where you have these growing up in India, you had these tutors who were these mega, had like 1 lakh kids, and you could teach, and they would make like crazy amount of money. I don't know how they did it, and had these. You could do that, right? You could be a global GI where you have GI shortage around the world. So I think we have to think broader than my office, my community, what I do on a daily basis, to say like, okay, this technology unlocks something across the board and I can really adopt it.
Any personal, individual career advice to gastroenterologists?
Career advice would be that understand what is happening. You don't have to be a technology expert, but understand the business aspects and how things will change with this kind of technology. What does that mean from a business perspective, and how are patients going to interact and everything? I think having that some mindset, yes, you should be clinically sound because that is what gets you moving. And that is why patients are coming to you, because ultimately I've done a lot of kind of primary research. Patients at the end of the day, ChatGPT or anything, want to hear that clinician's voice and in person and see and get an acknowledgement. So technology has not earned that trust yet. That is there. So understand and then create your own niche to drive with this. I think that's very important for GIs and people on the business side of things, right? If you were doing a certain way, you have to start thinking in different ways.
Sap Sinha, what a fantastic conversation. I thoroughly enjoyed and gained a lot from your insights. So thank you so much once again for coming on the Scope Forward show.
Thank you so much, Praveen, for giving me the privilege. And it was great conversation. Hope your listeners gained something. And, my thinking also improved as I spoke to you. So thank you.